Welcome back to Roadmap to Residency. Today we are attacking skin and soft tissue infections on Step 3, and we are doing it the way the exam actually asks about them. We will cover the diffuse spreading skin infection, the drainable abscess, honey-crusted lesions in children, shingles, and infections caused by resistant staph. This is not a lecture on microbiology. It is a strategy session on how these question stems are built and which single words in the stem hand you the answer. Work through your question bank and a solid review book alongside this video, because these patterns lock in only when you do many practice questions. Let us begin. Here is our plan. First, you will learn to recognize the buzzwords that separate a diffuse spreading skin infection from a drainable pocket of pus, because that distinction alone decides the answer on a large share of these questions. Second, we will look at how shingles and honey-crusted lesions are presented and what the single best first move is for each. Third, we will cover the risk clues that tell you to cover resistant staph, and we will learn to avoid the overkill answers that these stems are famous for. We will work through 3 full practice questions together and explain exactly why every answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is the most valuable one in this entire topic. Before you decide on any antibiotic, decide whether there is something to drain. Question writers signal a drainable pocket with a very small vocabulary. They will use the word fluctuant. They will describe a tender, mobile mass under the skin. They will mention a central point of pus, or they will tell you that a bedside ultrasound shows a fluid collection. The moment any of those appear, incision and drainage is your answer, and every antibiotic in the choice list is a distractor. Now flip it around. When the stem describes warmth and redness that is spreading, with a border you cannot clearly define, and says nothing about fluctuance, there is no pocket. There is nothing to drain. Antibiotics are the treatment. And in that setting, an answer choice offering drainage is a trap deliberately placed to catch you. So the first question you ask on every skin infection stem is not which bug. It is there a pocket? Second strategy. Once you know whether to drain, you have to choose coverage, and the exam tells you which coverage it wants through the risk clues it plants in the stem. If you see pus, an abscess, a boil, a wrestler, or an athlete sharing equipment, someone who lives in a prison or a shelter, a person who injects drugs, or a recent hospitalization, the writer is steering you toward resistant staph. Those stems want an oral agent with activity against resistant staph, such as trimethoprim with sulfamethoxazole, doxycycline, or clindamycin. Now compare that to the stem that describes spreading redness with no pus at all. That picture is usually strep, and an agent such as cephalexin is appropriate. Here is the part that catches people. When the stem gives you both a drainable pocket and spreading redness around it, your antibiotic must cover resistant staph, not just strep. Match your antibiotic to the clue the writer planted, not to the disease name that popped into your head. Now let us talk about the traps, because these stems are built around 3 of them. The first is the wound culture trap. Blood cultures and wound swabs sound thorough and careful, so they get placed near the top of the answer list. But in a well-appearing outpatient with a simple soft tissue infection, a culture does not change what you do today. Choose the drainage or choose the antibiotic. Do not choose the test. The second is the imaging trap. Advanced imaging appears as a choice precisely when the diagnosis is already obvious on physical examination. Save imaging for a suspected deeper process, a retained foreign body, or a diabetic foot where bone may be involved. If the stem hands you a clean bedside diagnosis, imaging is doing too much. The third trap is admission. Hospital admission with intravenous antibiotics is the classic overkill answer on this exam. It becomes correct only when you see fever with rigors, low blood pressure, a rapid heart rate, failure of oral therapy, a deep space infection, or a patient who simply cannot take medication by mouth. A comfortable patient with normal vital signs goes home on an oral drug. Let us work through our first practice question. A 28-year-old college wrestler comes to the clinic with a painful lesion on his thigh for 4 days. On examination, there is a tender, warm, raised lesion about 3 centimeters across with a fluctuant center and a small rim of surrounding redness. His temperature is normal, his other vital signs are normal, and he appears well. The question asks for the most appropriate next step in management. Before you look at the choices, ask yourself the question we practiced. Is there a pocket? And what risk clue did the writer give you about this patient? Read the 4 options carefully, commit to an answer, and then we will walk through the reasoning together on the next slide. Let us break it down. Spot the pattern first. The word fluctuant is the entire question. That single word tells you a pocket of pus exists under the skin. And the writer also told you he is a wrestler, which is a classic risk clue for resistant staph. He is afebrile, well-appearing, and his vital signs are normal, so this is a simple drainable collection in an otherwise healthy outpatient. Now apply the rule. A pocket of pus gets drained. Incision and drainage is both the diagnostic step and the therapeutic step, and for a small, simple collection in a well-appearing patient, drainage alone is sufficient. The answer is incision and drainage. Now let us eliminate. Choice A, cephalexin alone, fails on 2 counts. It will not drain the pocket, and it does not cover resistant staph in a wrestler. Choice C, admission for intravenous vancomycin, is the classic overkill trap. This man is afebrile with normal vital signs and looks well. He does not need a hospital bed. Choice D, magnetic resonance imaging, adds nothing when you can already feel the collection with your hand. The answer is incision and drainage. Here is our second practice question, and this one lives or dies on a single descriptor. A 6-year-old boy is brought to the clinic because of lesions around his nose and mouth for 5 days. Examination shows several small lesions with honey-colored crusts over a limited area of the face. There is no fever, no surrounding warmth, no swelling, and no fluctuance. He is otherwise healthy and is playing normally in the room. What is the most appropriate next step in management? Notice how carefully the writer told you what is absent. Every one of those negatives is doing work. Read the 4 choices, pick your answer, and let us walk through it together. Start by reading the descriptor. Honey-colored crust on the face of a young child is the single most reliable phrase on this entire exam. It appears and the diagnosis is made. Then look at everything the writer told you is absent. No fever, no surrounding warmth or swelling, no fluctuance. That combination defines a superficial and localized process, not a deep one and not a widespread one. Now, why does topical therapy win? Limited superficial disease of this kind is treated with topical mupirocin. Oral therapy is reserved for widespread lesions, for many lesions scattered across the body, or when multiple household members are affected. Choice B, oral trimethoprim with sulfamethoxazole, does too much for a few crusted spots on one small area of the face. Choice C, intravenous vancomycin, is the overkill trap in a well-appearing child who is playing normally in your examination room. Choice D, obtaining a culture before any treatment, delays care without changing what you would do. The answer is topical mupirocin. Now let us shift to shingles, and the strategy here is about a number the writer will always give you. Recognize the pattern instantly. Burning or tingling pain that arrives before the rash, followed by grouped blisters on a red base, confined to one strip of skin on one side of the body, stopping cleanly at the midline. That is shingles, and the writer will almost always tell you exactly which day the rash appeared. That number is the entire point of the question. Here is why. If you are within 72 hours of rash onset, you start an oral antiviral such as valacyclovir, which shortens the illness and reduces the risk of lingering nerve pain afterward. If you are beyond that window in a healthy patient whose lesions are already crusted over, antivirals no longer help, and the correct answer becomes pain control alone. And there is one exception you must never miss. If the rash involves the tip of the nose or the eye itself, that is a same-day ophthalmology emergency, regardless of how many days have passed. Vision is at stake. Here is our third practice question. A 70-year-old woman comes to the clinic with a painful rash on her right flank that appeared 2 days ago. That rash was preceded by 3 days of burning pain in the same area. Examination shows grouped blisters on a red base in a single band on the right side of her body, and the band does not cross the midline. She is afebrile and otherwise well. What is the most appropriate next step in management? Pay very close attention to the timeline in this stem. 2 separate numbers are given to you, and only one of them is the number that matters. Read the 4 choices and commit to your answer. Let us walk through it. Start with the timing clue. Grouped blisters in one band that stop at the midline preceded by burning pain is shingles. Now the stem gave you 2 numbers, 3 days of burning pain before the rash and 2 days since the rash appeared. The clock that matters is the rash, not the pain. 2 days since rash onset places her comfortably inside the 72-hour window, so starting an oral antiviral shortens her illness and reduces her risk of long-lasting nerve pain. The answer is oral valacyclovir. Now the key distinction, choices B and C, mupirocin and cephalexin, both treat bacterial skin infection. This is viral. Both are wrong regardless of timing. Choice D, pain control alone, is the choice that would have been correct if the writer had told you the rash was 6 days old and fully crusted over. That is the trap. They put the right management for a different timeline right in front of you. Here the rash is only 2 days old, so treatment is clearly indicated. The answer is oral valacyclovir. Let us close with the single most useful habit for this topic. Build yourself a trigger word list. Skin infection questions are won on individual words, and there are not many of them. Fluctuant means drain it. Honey-colored crust means topical mupirocin. One band of blisters stopping at the midline means shingles. Wrestler, prisoner, or a boil means cover-resistant staph. Train yourself to find that trigger word in the stem before you ever look down at the answer choices, because once you have it, the choices become easy to sort. Then, on your second pass through the stem, scan for the modifiers, because the modifiers are what change the answer. Look at the vital signs. Look at how many days have passed since onset. Ask whether the patient can take medication by mouth. Check whether the eye or the tip of the nose is involved. Notice whether an antibiotic has already been tried and failed. Those details are what decide between sending a patient home and admitting them, and between treating and simply controlling pain. Let us bring it home. Drill skin and soft tissue questions in your question bank until the trigger words are automatic and you can name the next step before you finish reading the stem. Go to the skin infection chapter of your primary review book, the infectious disease section of your rapid review resource, and the soft tissue infection explanations inside your question bank. Read every explanation, including the ones for questions you got right, because that is where the trap logic is spelled out. And when you are ready for personalized help, visit www.roadmap2residency.com, where our expert tutors and residency advisors can build a study plan around exactly where you are struggling. If this video helped you, please like the video and subscribe to the channel for more board review content. Good luck on your exam, and we will see you in the next one.